definition that you're looking at. Look at all these things, variously defined. Necessitates pulmonary specialist opinion, 10%, 16%, no definite discrete definition. This is probably a little better. It at least tells you that you have a minimum of 10 days of antibiotic therapy. It doesn't tell you whether the antibiotic therapy is right or wrong. The other thing would be radiologic opacities fail to resolve within 12 weeks. 12 weeks, a hell of a long time. And I think this is, of course, did raise my eyebrows. But then I thought, the question really would be that you have persisting radiological shadows. We now also very clearly know that it's not radiological shadows that are important, but you have a clinical response that is, again, extremely important. So we look at clinical response. This is really what you're looking for. You're looking for a heart rate which is less than 100, a blood pressure which is well above 90. You have a heart rate and a temperature which is normal. Along with this, if you have a total count which is normal, you can almost be very sure that you're looking at clinical resolution. So I think we need to differentiate between clinical resolution and radiologic resolution, and try and see how best we can bring these two things together. So anything that gets to me will stop working. So non-resolving pneumonia in the absence of clinical response, but then this is the clinical stability that we're looking at. So progressive increase in radiologic abnormalities. What have I done with that? Oh, it's become green now. That's wonderful. Patavi, I think, has influenced this. So progressive increase in radiologic abnormalities in clinical deterioration, median time to stability, 6% of progressive pneumonia. Evolution depends upon host factors. And I think one of the most important things that we need to understand with pneumonia is what is the background of your pneumonia. And I think I often think my teacher, Professor C.N. Devanagam, used to say, always, any disease, look at the background. Look at the background from which this guy is coming to you. Look at his background, whether it's asthma or COPD, more importantly if it's infections, because infections are something where if you make a mistake, you're probably going to land up in a mess, and that's a clearly rectifiable situation. You're dealing with a totally alterable situation. If you sort of make a mess of that, I think you have only yourself to blame. So please look at the background. Look at the background from which this guy comes, and you find out. This is, of course, wonderful statement from the ATS-ERS. This is the ATS-ERS position paper. Tells you that you're looking at the wrong organism, you have the wrong diagnosis, and of course you have complications. The wrong organism, of course, would mean drug-resistant pathogens. And I think there is this concept of thinking that every pneumonia that is non-resolving is drug-resistant. And I think that's something that we need to alter. Most of this so-called drug resistance happens because of us. Some of it happens in spite of us. So I think we need to understand that there is an approach to picking up an organism when we look at a pneumonia, and that's very important. We'll be looking at that a little later. We'll also be looking at drugs and the way we use drugs as such, and I think that's very, very important. Because one of the main reasons why we have drug resistance in the first place is because we not use the drugs rightly, and that's very important. So doing things right first, I think, is extremely important, and then you won't have the opportunity to correct it. I believe the great John McEnroe was once asked, how do you improve your second service? He was supposed to have one of the best second serves in tennis, and he said, you can't improve your second service, you have to improve your first. And that is very important. You look at pneumonia, you do the first things wrong, then you have a basket full of problem with you, and you're just not able to deal with it at all. So I think before we start treating a pneumonia, I think we need to have this mental picture of what we are looking at, what is the background that this guy comes from, and then we start proceeding. Look at complications. I think these are very important. Complications are offsets of the pneumonia as such. You have empyema, you have occult infection, you could have a drug fever, you have wrong diagnosis, again very important. Look at atelectasis, pulmonary embolism, pulmonary hemorrhage, underlying diseases, neoplasm. These are all things that we need to understand and appreciate. We're looking at them as we go on here. We just put this down: infectious complications, incorrect diagnosis, antimicrobial failure. Then you confirm compliance, you review, repeat a chest X. And I think a repeat chest X is something very important. Sometimes you become a little too frugal. I've taken an X-ray 4 days ago, so I won't take an X-ray, I miss a pneumothorax. I think this is very important. You know, once you get to a stage where you're looking at a pneumonia, and if you think that you're not so very comfortable, one of the simplest things that you can do is repeat a chest X-ray. Because I think if there is anything that's going to tell you anything about this pneumonia, it's going to be a chest X. It's not your mind. Your mind is already exhausted. You've done whatever you think you need to do, and I think you need to get help from somewhere. So you fall back on a chest X-ray, if necessary even fall back on a CT today, and I think that's extremely important. So we look at these things. Look at host factors, we looked at delayed radiologic recovery, presence of resistant organisms, unusual organisms, host defense. Again, you find the same thing being sort of typified differently. Advanced age, very, very crucial in pneumonia. You have an elderly person with pneumonia, you're asking for trouble. And I think you need to be doubly sure that you're putting your right foot first. So you have institutionalization, alcoholism, poor nutrition. This is the background that I was talking to you about. The background that sets the course for this pneumonia as such. You have host factors for poor prognosis, very young, extremely old, comorbidities, again very important. Look at comorbidities, look at diabetes, look at cardiovascular disease, look at renal disease, renal failure, leukopenia, bacteremia, signs, symptoms, dyspnea, gram-negative, institutionalization. Patients who live in institutions, for example, are prone, mentally retarded patients are prone for infections. We need to understand, again as I said, the background really comes in a huge way when we look at a situation like this. Of course, it's a nice split up. We need to know the bug before we think of the drug. I think that's very, very key. And I think even before we start an antibiotic, even before we send the first so-called sputum for analysis, I think there must be a mental picture of what we are trying to deal with. Many times we don't. We don't even try and find out, think if it's gram-negative or gram-positive. You can have a wild guess depending upon the spectrum that you're really looking at and the so-called background. But these are common organisms which are known to us. Strep pneumonia continues to be the commonest. Then, of course, H. influenzae and M. catarrhalis. Don't forget these three guys. These are the troublesome guys. These are the guys who can cause trouble for you. And I think trouble will come from the most unexpected quarters, as we like to look at it. So I think these are guys that sometimes you need to cover when you have a problem with you as such. So as far as India is concerned, I think there's a huge emphasis on empirical therapy, simply because the logistics of the way that we work doesn't really facilitate us trying in picking an organism every time. Many times it has to be empiric therapy, and you look at empiric therapy and you find that the remaining 46 cases did not have a bacteriological diagnosis. In spite of the most intensive investigations, including a bronchoscopy, you found that more than 46% of your patients don't have a diagnosis, don't have a bacteriological diagnosis. So the question of judging empiric therapy and getting empiric therapy right is extremely important. The goals, of course, would be minimize clinical outcome, maximize cost benefit, minimize spread of residue, and minimize selection of resistant flora. I think all these things are important, but I think also adding to this, I think, would be the question of trying to de-escalate as quickly as possible. We're talking about de-escalation a little earlier on, because I think it's not the question of starting an antibiotic, it's not the question of maintaining an antibiotic, but I think our fingers itch till we really try and get this drug off, and I think that really should be the way that we look at the pneumonia as such. So treatment failure, we've already seen that: host, drug, pathogen, other conditions. Complications, we have seen that already. Host factors, we talked about age, we talked about comorbidities, diabetes, alcoholism, immune suppression. Look at radiological recovery, and then I said, this is probably a very exclusion of these for CAP, far number outweighing pneumonia. Important to know what time frame it takes for radiologic recovery. So I think it is important for us to understand that, as I told you, clinical recovery is more important than radiological recovery. And I think this is something that should be supermost in our mind. Radiological recovery is something that can sometimes take a little more time than clinical recovery. We look at clinical recovery first, and I think we shouldn't really be waiting for radiological recovery before we start doing something. So when do you suspect resistant pathogens? You suspect a DRSP treated with beta-lactams. And I think this is important. Many times we never find out what drugs this guy has taken before he comes to us. We don't have the time to do it, or we don't have the intent to do it. For whatever reason, I think this is extremely important. Before we prescribe an antibiotic for a pneumonia, please try and find out what has been the medication that he's taken. He probably has been medicated extensively by the time he has come to you. And I think you need to take that into cognizance before we try to do something. So dose exposure given, young children, pneumonia in the last 1 year, hospitalization, then you have significant resistance potential. And I think the logic of antibiotics needs to sort of defer to this 4 Ds, as we call them. We call the drug, the dose, the duration, and of course the de-escalation. The 4 Ds of antibiotic therapy, I think, are important. the drug, the dose, the duration, and of course, we de-escalate as quickly as possible. All guidelines will talk about the entity of de-escalation. I think this is so very important today for us. So how do you approach an infection by itself? The first thing is to find out, is it an infection? What is the type of infection? How severe is the illness? And I think the use of severity parameters, which we're looking at, like the Curb 65 or the Smart Corp, for example, I think those are very simple things that we can look at to try and tell you what it's like. How do I identify the causative pathogen? Is pathogen identification necessary? And I think a lot of people will be asking us this question. In a country like India, do we really need to go searching behind this so-called organism that has become so elusive to us today? So I think we need to understand, need to look at everything. So I think a look at drugs is important. What do drugs mean to you? And I think look at the first generation cephalosporins, of the second generation cephalosporins, the third generation, then you have the non-pseudomonal, then the anti-pseudomonal, ceftazidime, cefoperazone, cefepime, and to add to this confusion, you have multiple combinations, BL-BLI combinations. With clavulanic acid, you have every drug combined with clavulanic acid today. It's like a statin, for example. You know, like yesterday I was saying, somebody was asking me about montelukast and levocetirizine. I said tomorrow you'll get a combination montelukast with atorvastatin. And that's the type of country that we live in, and I think we need to put up with all these things as such. So I think it's important for us to understand that we have far too many drugs. And sometimes I think it may be easier to practice in the West where there are so many limitations on the prescription of drugs. I think we have such a free hand today, and we are such a free democratic country that we cannot really agree upon anything, right from Kudankulam downwards. So I think you look at the fluoroquinolones, and I think just one word about the fluoroquinolones. I think if there is one group of drugs that has been grossly abused and misused, it has been the fluoroquinolones. For various reasons. For reasons that the fluoroquinolones had so much of hype when they brought in the drugs into the market, and I think it's important for us to understand that. And they sort of literally faded away, honestly, for various reasons. And I think that's very important. Again, that only shows the fact that our approach to fluoroquinolones had not been, I should say, less than dicey, I would like to call that. So I think the fluoroquinolones are a group of drugs which need to be used with a great deal of caution in a country like India, especially because of the activity on MTB. So the question of tuberculosis, I think there are many people in this country today who feel that the MDR that we are looking at today and the XDRs that we are looking at today is probably the mess that has been created by this huge abuse of fluoroquinolones that we have had over the past 10 to 15 years, the time that they have really been in. So we need to be careful about the fluoroquinolones. Whatever drugs that we're really looking at, respiratory or non-respiratory, look at the aminoglycosides and the spectrum and the positioning, and look at the macrolides with the advantages, of course, of being effective against atypical microorganisms. So miscellaneous drugs like clindamycin, metronidazole, vancomycin, teicoplanin, and linezolid, and of course the gram-negatives like tigecycline and colistin. These are the drugs that we really fall back upon when everything is lost and we have nothing to gain, and that's really the way that we look at it. Where do you get enteric gram-negative organisms? Nursing home residents, cardiopulmonary disease, multiple medical comorbidities. Pseudomonas always look at a disorganized lung. I think that's very important. You have a structural lung damage, 8 out of 10 you have pseudomonas. There's no question about it. You have bronchiectasis, 8 out of 10 you have pseudomonas. You have post-tubercular sequence, 8 out of 10 you have pseudomonas. And I think this is a very important drug because pseudomonas can become resistant to just about everything. We have seen that on so many occasions. We need to understand that it's got a huge ramification. Look at MRSA, burns, surgical wounds, soft tissue infections, tertiary care center, acute nursing homes. As I said, the background I think is important. For all these drugs, the background does become important. For penicillin-resistant pneumococcus, again, as I said, the background, recent current hospitalization, recent antibiotic use. So I think these are things that we need to consider before we really start getting them in. Now, how quickly do you get your antibiotic in? I think this is extremely important as far as a country like India is concerned. And the fact that we need to choose the right empiric therapy in patients with pneumonia. The so-called door-to-needle time that they like to say in patients who are admitted with pneumonia, 4 hours door to needle time, there's enough literature to tell us that 4 hours reduces not only mortality but also reduces hospital stay. So within 4 hours, you should be able to decide what is the type of antibiotic that you're going to get. And I think you need to do this based on 2 things which can be available in 4 hours. First is a simple gram stain if it's possible. And the second is simple white cell count if it's possible. These 2 simple measures can tell us what is the level of antibiotic therapy that we need to use. Can we do with a simple second generation cephalosporin, leave it with that? Do we need to go to the carbapenems, or do we need to use one of these bridging drugs like cefepime tazobactam for that matter, you know? So you need to place these things as such, and 2 simple things are good enough to guide us during those phases as such. So that the door to needle time, I think, is extremely important in situations like this. Mechanisms of resistance, of course, would be beta-lactam resistance, and you have the porin loss, and you have the efflux pumps. But basically, I think this is something that we need to look at. There are 2 groups of antibiotics that we're looking at. We have concentration-dependent antibiotics and we have time-dependent antibiotics. And I think there is a clear difference in the usage of these antibiotics, as we shall see. You look at concentration-dependent antibiotics like the fluoroquinolones, for example. Fluoroquinolones and aminoglycosides, you give a large dose, single dose, because you need a peak. The higher the peak, the greater the killing capacity, and that's really what it's all about. So the peak matters in these patients, and that's the reason why all these drugs are given in big doses, as single doses, whether it's a fluoroquinolone or an aminoglycoside. That's the way they work. You look at an AU-MIC of greater than 100. Where you look at the T greater than MIC of greater than 40% of dosing interval, you're looking at the cephalosporins, and the cephalosporins have this. They have a time-dependent killing sequence where you see that the time that they spend above the MIC is directly proportional to the volume of bacterial killing that they do, and I think this is important for us to understand. So you need to use cephalosporins either in repeated doses or use them as infusions. Like imipenem, for example, I think there's a huge thing of using imipenem twice daily. You might as well not use it at all. So it's very important that you infuse a drug like imipenem for that matter, and then use it for about 8 hours, and then the next 8 hour infusion starts after that. So it's very important to differentiate between concentration dependent and time dependent killing when you look at bacterial, antibacterial antibiotics that we're really using. It's important to understand and conceptualize this so that we are in a position to sort of put it into practice. So time dependent antibiotics give frequent doses, give prolonged infusion. Concentration dependent antibiotics give single dose or high dose. And these are the drugs that we're really looking at, as we've already seen. So we look at the comorbidities. These are the ones, the basic comorbidities, very important to really look at that. We look at the etiology of non-resolving pneumonia. Tuberculosis, I think, should land high, right up the list of drugs. For some reason or the other, we sometimes either overdo the AFB or we don't do the AFB at all. You know, we never really hold this middle ground and say, okay, I look for the AFB, I look for something else as well. We are so shut up in our minds that we don't really do this. De-escalate, come out as early as possible. I think this is important. You can de-escalate only if you pick the organism. If you don't pick the organism, then you don't de-escalate at all. What do you de-escalate upon? So this is important that the picking of the organism not only helps you to select the right drug, but also come out of the wrong drug, which is again very important from the long-term point of view. So de-escalation has clear outcomes. There's no doubt about it. And I think one cannot stress and re-stress on this. Simple hand washing from patient to patient, and I think this is important. I think how many of us do it in a busy practice, in a busy hospital for that matter, bed to bed, somebody's calling, and you're signing something in the middle, the nurse comes up with a sheet and does something, and then you're out into the next bed with the same hand, and the Pseudomonas goes from bed to bed. And I think that's really what we're looking at. So this is something that we can change, and I think we need to change. We need to make a difference here. So MRS, we've already seen this. Unusual organisms like tuberculosis, Nocardia, atypical mycobacteria, lapses in defense mechanisms. I think we'll skip all this. Not so. Look at inflammatory causes. Vague out things like systemic vasculitis, Wegener's, you have BOOP, you have PAP, you have sarcoidosis, you have AIP. Drugs, never forget drugs as the cause. Nitrofurantoin, right up the list. Amiodarone that we know, methotrexate, bleomycin, mitomycin, paclitaxel, docetaxel. All these drugs, never forget drugs as a cause of resistant pneumonia or non-resolving pneumonia. So I think that's really what it is. We review antibiotic. review the sensitivities, you repeat a CXR, probably do a chest CT, do an echocardiogram to see if you're developing an empyema, for example, or a collection of fluid that needs to be let out, and I think this becomes important again. Simple gram stain, we've already talked about that, is sensitive, not specific. Contamination of upper airway, again we need to understand that these are contaminated by the upper airway, which again I think gives importance to the fact that we need to be frugal with the use of antibiotics in these patients. So repeated radiological investigations. We look at 2 X-rays, and I think this will teach us a lot. This X-ray on the left that we're looking at with the left upper lobe shadow, 8 out of 10, I think 8 out of 10 of us will say this is probably tubercle. In fact, we may not even look for another organism. And I think this is something that we need to change. We need to change this mindset and make sure that we look at the bacteria before we say that this is what it is, and this is what it finally turned out to be. So this was Klebsiella with the left upper lobe shadow. If I had done a CT in this guy, I would have really found those bulging fissures that we see in Klebsiella. Now that's what we mean when you sort of think out of the box and don't be narrowed out in your thinking about TB, for example. I'm not saying that TB is not the commonest. I'm just trying to say that there are mistakes that we can make, and I think we need to sort of think out of the box in situations like this. Look at X-ray number 2, again very important, bilateral basal shadows. Everything goes negative. You do a bronchoscopy, what do you come up with? You come up with bronchoalveolar carcinoma. So I think this is important for us to understand the sequence of what we are looking at, think out of the box, and make sure that we cover every single alternative possible. That's one. The second is, if you're not able to get an organism as quickly as possible, as simply as possible, I think an FOB is an absolutely must in these patients. Absolutely, no question about it at all. The point really is, in this situation, many of us would have resorted to this terrible practice of giving him a course of antibiotics and repeating an X-ray after 3 weeks. It'll be 3 times his size by the time you get at him 3 weeks down the line. So it is important that if you're not able to get the organism in one go, there's no point in saying, okay, I will take the second go after a course of antibiotics. Your chance of getting the bug on the second course is less than 10%. So there's no question about it at all. So we need to make up our minds about this, and then we see what we can do. Again, a very interesting example. You look at this left parahilar shadow, everything done, everything negative, and finally we gave him antituberculous treatment. This was sputum negative, repeatedly sputum negative, in spite of a bronch, and we find that there is tremendous clearance. So I think we have 2 ends of the stick here, really. We have 2 ends of the stick. One end where you need to be very empirical and think of what you do. The other end, of course, you try and hunt for every organism that's possible. But I think the bottom line remains that if you're not able to identify an organism in a significant chest shadow that you're really looking at, please look at other modalities. Look like a bronchoscopy or a CT scan for that matter. Now this is quite okay. This is strep pneumonia. It's not a real problem as such. I don't think this is going to be a problem. This is staph. You do a CT in a staph, and I think it will sort of hit you in the face. There's no doubt about this at all. So this is not a problem. Again, these are simplest things that we can do. Look at the Klebsiella that I spoke to you about, the bulging fissure that you see. 8 out of 10 Klebsiella will have this on the CT. It's a beautiful sign that cannot occur with just about any other organism, the so-called bulging fissure sign that we see in patients with Klebsiella, and again, that's become important. This, of course, with a blind eye, you can call this Pseudomonas. There's no doubt about it at all. You have multiple structural lung changes, and this is Pseudomonas without question. So the question of bronchoscopy, I think, becomes important. The question of using bronchoscopy and all the wonderful techniques that Patabi spoke about. I think this is important for us to understand that the bronch is a very vital ingredient in preventing non-resolving pneumonia. We understand that as well. Protected specimen brush in many patients. It's of use. The usefulness of BAL in patients. But finally, what do you do? Reevaluate host factors, elderly, alcohol, corticosteroid, COPD, review microbiologic data, repeat the CXR, repeat the CT scan, then you repeat respiratory sampling in the form of a BAL as such. This is a cycle that needs to keep going round and round till we try to finish what we are. We looked at risk, and we look at risk stratification. This is the port. The port is a very complicated way of looking at it. Institutions can have the port to try and calculate the risk as such, but I think on a one-to-one practice, the port is probably not the best that you can use. The best that you can use, I think, is the curve 65. This is from the BTS. The curve 65, the 1, 2, and 3, that we're really looking at the 2 groups, and you find that they are beautifully laid out as far as therapy is concerned. Group 1, which is home care, group 2, which is hospital assessment, and group 3 and 4, of course, go into the ICU. So the curve 65 is a wonderful index that you can use in such patients. There is also something called the SMART COP. This has come with the Indian guidelines that have been published. The SMART COP again has a minimum score of 11, and then this is scored along these lines. So I think we need to adapt some sort of scoring system about which we become extremely familiar, so that it tells us where we treat our patients, where we can avoid this sort of non-resolving pneumonia as such. So there are a lot of talk about procalcitonin and CRP as an index. Procalcitonin is very expensive, done in very, very few places, so we won't really talk about procalcitonin. CRP is probably more of an index where it is persistently high in patients and it doesn't really come down. That probably depicts the fact that this is an infection that is going to be progressive and probably not very responsive to therapy. Acute CRP increases could also reflect the fact that you're dealing with difficult organisms and we're not really controlling the infection as such. But I think in the acute phase, I don't think a CRP can do anything more than a simple white cell count. A white cell count will tell you that the infection is coming down. What is 16,000 on day 1? If it becomes 8,000 on day 3, you know that you're working right. So there's no question about it. A simple white cell count. But there are certain instances, especially in COPD exacerbations, for example, if you have an index CRP which is high, even after the end of the exacerbation, you know that the next exacerbation is coming. So I think we need to understand that CRP has some sort of prognostic significance in situations like this. Vaccines, again, are very important for patients who go back with pneumonia. A pneumococcal vaccine, whether it is 23 valent or 13 valent, it's a choice of yours. But I think the question of vaccinating these patients are important, at least in the pneumococcal vaccine and the influenza vaccine, I think are very important. So we'll just study some lines. Don't use fluoroquinolones for strep and staph. Drugs which cover only gram negatives. Prefer not to use them unless you really pick them up. Drugs which cover only gram positives, again these are drugs that need to be avoided first line, especially as empiric therapy. Make sure that you have evidence. Surgical prophylaxis, you have 3rd, 4th generation cephalosporin. Surgical prophylaxis should be given 30 to 40 minutes before infusion. Ceftriaxone and levofloxacin are not small antibiotics. There are a lot of people who feel that ceftriaxone is one real bottom of the line drug, like you throw it from the bottom. It's like one of those 9-pin balls that we play. Please understand that ceftriaxone is an extremely potent drug, and we need to consider this in a very, very classic situation. Learn to say no to vancomycin. Don't use vancomycin for sensitive staph and strep. Avoid bacteriostatic drugs, macrolides, linezolid, tigecycline in immunocompromised patients. The carbapenems are as good as monotherapy for high risk and mixed infections. No need for metrogel with them. We need to understand that it would be better to use the carbapenems in isolation because they cover just about everything, depending on what you're using, whether you're using piptazo or whether you're using meropenem. I think it is important that we don't really combine a lot of the cephalosporin, for example, with the carbapenem. It doesn't really make much sense at all. So we need to be careful in the use of these molecules. We also understand that the illogical BL-BLI combinations, and I think if you ask me today, how many BL-BLI combinations do we have in this country, I don't know. I think you will need a huge computer to calculate the number, and even that may go for a 6. Looking at the number of BL-BLIs that we have, every single drug is combined with a BL-BLI combination. So this is from the ATS-ERS, clinical parameters used to define response. Do not change therapy for 48 to 72 hours. Extremely vital. 24 hours antibiotic, no response, change. And then the next 24 hours you get another drug, and finally your pharmacy will be empty. You won't have any drugs to administer. So it is important that we maintain these drugs at least till we get our cultures or whatever that we're waiting for. And that's the most important thing. When we use a drug in the first place, we need to have something at the end of 48 hours that we are looking for in the form of a culture, in the form of a gram stain, in the form of something for that matter, to see if we can alter this antibiotic therapy. So responsive patients should have de-escalation of antibiotics. Non-responding patients should be evaluated for non-infectious mimics of pneumonia, unsuspected drug resistance, organism, etc. So I think it's important to that. How do we teach our patients? How do we treat our patients with pneumonia, for example? How many of us talk to our patients? How many of us talk to our relatives in patients with pneumonia? I think we need to probably smile a little more. These are patients who are very sick. A smile costs nothing, but it creates much, yet it cannot be begged, borrowed, or stolen, for it's worth nothing to anyone until it's given away. And I think we are very poor smilers. We never smile. We always have this sort of morose thing, but because we're waiting at the next patient. No? Somebody is waiting down the line, we have this sort of real morose face that tells, there's only one message that we give this pathetic patient of ours: get out as quickly as possible. So I think it is important that we understand that these are people with problems, and we need to understand that they have come to us because they are suffering, and we need to alleviate their suffering. As a child, I used to listen to a radio station called The Voice of America. I don't know if you've listened to that. I always remember this guy with a gruff voice who used to say, if you find somebody without a smile, give him one of yours. I'll never forget it all my life. It keeps ringing in my ears even at this very minute. So I think we need to smile a little better. Do we hear patients or do we listen to them? I think we'll pick up a dictionary and find out what is the difference between hearing and listening. Hearing is when I hear something in the next room. Somebody sings in the next room and I hear. I hear not because I want to hear, but because I have to hear, otherwise I'm deaf. That's the reason why I hear. Listen, I want to listen to what you're trying to tell me. And that's what we should be doing to patients. But unfortunately, what happens, this patient of mine is sitting by the side, says, sir, I got up at 2 o'clock in the morning, I had a severe wheeze, I took my salbutamol, I opened the window and drank a cup of coffee, tea, and whatever. This goes on in a story. At the same time, I'm writing something, the nurse is walking in with the sheet and I'm signing that, and there is a call from the ward, there is a call from home. You have to do that, otherwise your house door will get locked out and you'll be locked out on the street. So there are too many things that we need to look at. And I think we are multitasking. We are wonderful multitaskers, and this poor patient keeps going on and on and on and on. So I think we need to understand that we need to listen to him. This is our bread and butter. And if you're not looking at bread and butter, what else are you really looking at? Pros and cons of treatment. I think this is something, I really learned this lesson very hard. I often tell it in all my talks. There was this girl who was admitted with acute asthma, for example. She had a huge asthma exacerbation. Bed 3 in the ICU. I see her. She's out.